Good morning, everyone. I'll be presenting today on BRCA mutations, HRD testing, and PARP inhibitors in ovarian cancer. So, coming to BRCA mutations, BRCA1 was discovered in 1990 based on the seminal paper by Mary Claire King, where they linked early onset familial breast cancer to chromosome 17 Q21. So, some details about BRCA1: it is on chromosome 17, and it is crucial for DNA repair via the homologous recombination, which I'll come later, which I'll talk about it later. BRCA1 mutation carriers have 39 to 44% risk of ovarian cancer versus 1.3% in general population. 15 to 20% of high-grade serous ovarian cancers harbor BRCA mutations, either germline or somatic. 75% of them, 75% of the BRCA1 mutations are usually diagnosed at an advanced stage and are strongly associated with the serous subtype. BRCA1 mutated ovarian cancers are more platinum sensitive and have better OS than BRCA wild type. And some PARP inhibitors like olaparib improve PS significantly based on this. And the risk reducing salping oophorectomy, which is usually done at 35 to 40 years, reduces the risk by more than 80%. BRCA2 was discovered 5 years later in 1995 based on this paper published in Nature by Richard Wooster, which identified BRCA2 to chromosome 13. And this also is involved in DNA double-stranded break via homologous recombination repair. The mutation carriers have 11 to 17% lifetime risk of ovarian cancer, lower than BRCA1 but higher than the general population. BRCA2 mutations, germline and somatic, both are present in around 5 to 8% of high-grade serous ovarian cancers. It is usually autosomal dominant with high penetrance and part of the hereditary breast and ovarian cancer syndrome. And also BRCA2 mutated ovarian cancers are highly platinum sensitive and are associated with better OS than the BRCA1 mutated tumors. So this is a pie chart which shows approximately 50% of the high-grade serous epithelial ovarian cancers have alteration in the homologous repair genes. As you can see on the right side, there are all homologous deficient genes where BRCA1 germline is 8%, BRCA1 somatic is 3%, BRCA2 germline is 6%, and BRCA2 somatic is 3%, and other are homologous recombination repair deficient genes. Like you have Fanconi's CDK12, BRCA1 promoter methylation is also leads to homologous deficiency. The relative risk when a woman with a mother has ovarian cancer is around 6. When her sister has ovarian cancer, it is 3.8. A daughter with ovarian cancer leads to relative risk of 1.1. And if a woman has two close relatives with ovarian cancer, then the risk of developing is around 40%. So factors which suggest the possibility of BRCA mutation in a patient is that breast cancer diagnosis before the age of 50 years, bilateral breast cancer, occurrence of both breast and ovarian cancers, tubal and peritoneal cancers, breast cancer in one or more than one male relative, multiple cases of breast cancer in the extended family, one or more family members with two primary types of BRCA related cancers, and Ashkenazi Jewish ethnicity. So these are the various DNA damage pathways. As you can see on the left side, first is a single stranded break where it is repaired by base excision repair, and the important gene involved is PARP1 in this and XRCC1, which I'll explain later. In the double stranded break, there are two mechanisms by which it can be repaired. One is the non-homologous end joining, which is error prone mechanism, and the important one is the homologous recombination. So here you can see on the right side. So when there is double-stranded DNA break, normally the mRNA complex gets activated, and that leads to activation of the ATM. Then there is recruitment of BRCA1, TP53, and CHEK2, which leads to further recruitment of PALB2, BARD1, and BRIP1, leading to activation of BRCA2. And this leads to a penultimate pathway, which is the formation of RAD51 complexes by BCD, which leads to activation of the ligases, and then the process of DNA repair. The third pathway is the nucleotide excision repair. This is when the bulky headaches and intra-strand crosslinks are formed. This is usually seen when this is the mechanism of cisplatin actually, and cisplatin related DNA damage is repaired by this nucleotide excision repair. And last one is the base mismatch, and this is also important in ovarian cancer because this leads to mismatch repair. And the genes involved, these are Lynch syndrome genes, whereas MLH1, PMS2, MSH2, and MSH6. And so any deficiency in this leads to mismatch repair. And in such patients, immunotherapy plays a role. So this is a easy version of the previous slides. So first, the double-stranded DNA break is recognized by the mRNA complex, which is made up of MR11, RAD50, and NBS1, which senses the double strand and activates the ATM. And then these break ends are processed by recruitment of BRCA1, check1 and check2, and a single stranded DNA is formed at that double stranded break, and this break is stabilized at their ends by RPA, which coats the double single stranded DNA and stabilizes that, and in turn it activates the ATR. And later, through the penultimate step, PALB2 BRCA2 leads to accumulation of RAD51, and after that, the double stranded breaks are repaired. So these are there are many HRR genes depending on the panel we do, but these are the most representative genes which are involved in any panel. As we can see here, there are multiple genes, but the important one to note is that TP53 also is a part of HRR gene, and MSH2 from the Lynch syndrome also is a part of HRR gene, and of course BRCA1 and BRCA2. So coming to HRD, homologous recombination deficiency. So it is basically inability to repair DNA double-stranded breaks via homologous recombination repair, which I showed you previously. And it leads to genomic instability and cancer development. When HRR is impaired, repair shifts to error-prone non-homologous end joining. And this leads to chromosomal aberrations and malignant transformation. So because of this non-homologous end joining, there will be multiple scars on the genome, which is called as genomic scars, which are markers of HRD. And the three types of genomic scars are: one is loss of heterozygosity, telomere allelic imbalance, and large scale state transitions. And 1 plus 2 plus 3, the combination of this is called a genomic instability score, which determines the HRD status. So on the right side image, you can see that around 50% of the ovarian cancer patients are HRD negative, whereas 50% are positive. And in those 50% who are positive, 25% are due to BRCA1 and BRCA2 mutations, and 25% are due to non-BRCA HRR genes. So testing for HRD can be based on two different mechanisms. One is to find out the cause of HRD, like genetic mutations in BRCA1, BRCA2, or the HRR genes which I showed previously. Or we can see the HRD through consequences of HRD, just as genomic scars, which I'll explain, and modern assays like Myriad, MyChoice, and Foundation 1 evaluate all three aberrations for better sensitivity. So coming to the first, which is the cause of HRD, also known as genomic perturbations. So main driver will always be the BRCA1 and BRCA2, where germline BRCA1 BRCA2 is found at 13 to 15%. So because of this, universal germline testing is recommended. Somatic BRCA1 BRCA2 is only found in 5 to 7% of the cases, and also it is associated with similar outcome. So it is important to check somatic too. BRCA mutant tumors derive the greatest benefit from PARP inhibitors and platinum-based chemotherapy across all major trials. Up to 30% of the ovarian cancers harbor alterations in other HRR genes such as RAD51C, PALB2, BRIP1, ATP, CHEK1-2, CDK12, and Fanconi syndrome. And this is known as BRCA-NES phenotype, when non-BRCA HRR genes are involved. So retrospective analysis have showed that non-BRCA HRR gene mutations are associated with PARP inhibitor benefits too. Also, now we are able to find out that BRCA1 promoter methylation also is involved in HRR, and that leads to HRD, and hence PARP inhibitors can work in them too. So chemotherapy causes demethylation, and that leads to restoration of the HR proficiency. So a patient who is HRD can become HRP when we give chemotherapy due to demethylation, and that reduces the sensitivity of PARP. That is one of the reasons for resistance to PARP inhibitors. And standard germline or NGS testing which we do misses epigenetic modification, and that's why comprehensive HRD testing like the MyChoice is important. So coming to markers of HRD, the first marker is the loss of heterozygosity. Basic that from each of our parent we get each allele for a gene, and if there is loss of one allele, that leads to homozygosity, because the heterozygosity is lost and the remaining allele can either stay like that or it can duplicate and become homozygous. So the second marker of HRD is telomeric allelic imbalance. So telomeres are basically the ends of the chromosome, and so basically you will have two telomeres there, and on one side if the telomere shortening happens, then there is unequal amount of genetic material from the two parental copies, and that leads to chromosome break and hence the genomic scar. Third marker of HRD is large-scale state transitions, where chromosomal breaks between two large adjacent regions happen, and that size is almost more than 10 megabase pairs. And through their artificial intelligence, they calculate the genomic instability score based on loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions. So here you can see on the left side, the cause of HRD is found through either mutations or through epigenetic mutations. And on the right side, you have consequence of HRD, which is phenotypic. And here you see through the LOH, LST, and TAI. Also, there is so because they tell that these are static tests, okay, because HRD is a dynamic process and it can change throughout the patient's history with treatment. So nowadays they are trying to find out something which is more dynamic, so we can give a real-time estimation of the HRD, and that is through RAD51 functional assay. So RAD51 functional assay is basically immunofluorescence test. So for patient to become HRP, basically that homologous recombination proficient, so you need the penultimate step before the DNA repair happens. And if you see in the previous slide here, the penultimate step is the RAD51 complex formation. Only after that the repair happens. So if you find in immunofluorescence RAD51 foci, then it means that it is proficient. If you don't find RAD51 foci, meaning that the previous genes are lost, like PALB2, BRCA2, and that leads to homologous repair deficiency. So there are only two HRD testing platforms which are HD approved till now. So first is the Myriad MyChoice CDX, approved in 2019, and it is endorsed by both the ASCO and ESMO, and takes into account both presence of mutations and the genomic instability score. And the threshold of more than 42 is used to distinguish HRD positive and HRD negative tumors. The second is the Foundation 1 CDX, which was approved in June 2020, and this relies on something called only on the LOH, which I explained here, loss of heterozygosity, and doesn't take into account the tumoric allelic imbalance and the large scale transitions. And the percentage cutoff is 16 for Foundation 1 test. So the choice of HRD genomic score is that the MyChoice uses genomic instability score, whereas the Foundation 1 uses only the loss of heterozygosity. So the concordance, there are some concordance issues with these tests, because if you see that there was a retrospective trial of 3,336 patients, in that they found out that among BRCA wild type tumors, 53% of MyChoice positive cases were negative by Foundation 1, whereas only 4% of the Foundation 1 test patients who were positive were negative by MyChoice. So that's why both ESMO and ASCO recommend MyChoice to be done compared to Foundation 1. And the cutoff difference also matters, because in some trials they use 33 and some trials they have used 42, and the 33 was based on some xenograft models which they did, and there is no actual basis for 33. And these assays are not equivalent because there is no head-to-head comparison between these two platforms. But the important thing about Foundation 1 is that they provide extra details like tumor mutational burden, MSI status, and optional CPS PDL1, and which can guide immunotherapy in these ovarian cancer patients. So if you are looking at HRD for selecting PARP, then MyChoice is preferred. But if you want to know broad genomic and immunotherapy markers like PDL1, TMB, and MSI, then Foundation 1 adds value. So MyChoice, of course, outperforms other HRD tests, but as such, FDA has approved both MyChoice and Foundation 1. So these are the functional tests. I'll explain only about that RAD51 foci assay. So when we introduce double-stranded DNA breaks in the cells, so these cells can be seen through the microscope by doing an immunofluorescence, where a RAD51, if we find out that RAD51 is there, it means that it is HRR proficient. On immunofluorescence, if we don't find the RAD51 to be fluorescent, then it means that it is negative and it is HRD deficient. So basically the same thing which I explained, approaches for testing HRD. So initially HRD test is based on two things, but now recently they've added the third functional test, which is the RAD51. So mutations, the cause of HRD can be found out by seeing the mutations, either BRCA or non-BRCA HRR gene. And in between you can see the consequence of HRD can be found out by seeing the genome instability score or the loss of heterozygosity based on what platform we are using. And the commercially available tests are these various, but only first two, the MyChoice and Foundation 1, are approved here. The other, like molecular intelligence by Carries, Tempus, Amoy, and Sophia DDM HRD. The Sophia DDM HRD is what we use in our hospital. And this is actually based on only, so this checks only the BRCA mutation, HRR genes, and loss of heterozygosity. So this is basically based on the Foundation 1. Sophia platform is based on the Foundation 1, but the only difference is that the actual Foundation 1 checks 324 genes, whereas we check only 28 HRR genes.
But we give genomic integration.
See, how do you read? You must know the TMH protocol, I mean the Sophia DDM software. Have you got an HRD report?
I've
How do
got
you read it? How do you finally find out whether HRD is positive? What is the role of GIS score in our report? Because the myriad choice, the threshold is more than 42.
yes.
That is not what is there in our report.
Our
Mumbai,
report.
you told, na, 28
Yes.
HRD,
We check only 28 actually.
BRCA, loss of heterozygosity, and GIS score, anything which is positive is considered positive.
Yes, ma'am.
The difference between Sophia software and my choice. So I almost sounding like one of those MRs. Always behind my choice and foundation.
Genomic integrity score is a combination of three.
Yeah, a combination of
But
three.
here we are checking
Our threshold is anything which is positive is taken positive. A Sophia platform is different from the
Yes.
so that you must know whatever TMH we are following.
So coming to synthetic lethality concept, here you can see that in BRCA wild type non-HRD, which is normal gene, when the single stranded break happens, it is usually repaired by the base excision repair, and if this is missed, then double stranded DNA break happens from single stranded, and it is repaired by homologous recombination proficient cells, and cells survive. But in BRCA mutant patients, when the single stranded break happens, the base excision is repaired, and if it is not repaired, it leads to double stranded DNA breaks. But because these are homologous repair deficient and the cells do not survive, so what happens is if you introduce PARP here, base excision repair, it inhibits basically the single stranded break repair. And if you inhibit the single stranded break repair and then when it leads to double stranded, in these cells which are deficient, there is no way the DNA is repaired again now. And even if it is repaired, it will be repaired by error prone mechanisms like the non-homologous end joining, and that leads to death of the cell. So these are some of the mechanism of PARP inhibitors. So basically PARP, it competitively inhibits the NAD catalytic binding site of the normal PARP enzyme. So because of this, there will be inhibition of PARP, which leads to PARP trapping at the ends of the single-stranded DNA breaks, and that leads to replication fork stalling, and hence the double-stranded DNA breaks and death because they don't have the homologous repair proficient genes. So also there is upregulation of the NHEJ, which is non-homologous end joining, and this leads to error-prone mechanism of DNA repair, and hence again increased DNA damage and death cell. Also, it has been found out that PARP inhibitors increases the rate of replication speed. When the replication speed increases, of course, the errors are more, and hence the DNA damage is more, and it leads to cell death. So this is same. So shifting treatment paradigms for PARP inhibitors is that, so initially in 2014, olaparib was approved for germline BRCA mutated advanced ovarian cancer after 3 or more than 3 prior chemotherapies. After that, rucaparib was approved for 2 or more than 2 lines. Then came the maintenance therapy in platinum sensitive relapse, where study 19, which included olaparib, showed increased PFS, and also niraparib and rucaparib in this platinum sensitive relapse maintenance setting. Then the PARP inhibitors came to the frontline setting, where after CR or PR post frontline chemotherapy, maintenance PARP was given, and this led to 5-year relapse-free rate of almost 50%, reaching to almost potential cure. And then for this PARP inhibitors, bevacizumab was added in the Paola trial, and that was positive. And the greatest benefit with PARP inhibitors is seen with BRCA mutant patients compared to non-BRCA HRD positive, which have moderate benefit, and then HRD negative who have minimal benefit. So these are some of the key trials which Dr. Swapnil will explain next. And so here you can see that. So I have marked this because so in this box you can see these are HR non-determinant. So sometimes you can see in our HRD test we find out that HR is non-determined or undetermined. So even these patients were taken in this trial, but all these trials have found out that such patients don't have statistical significant benefit, if you see. But so olaparib, so basically these are all frontline setting. Solo one is for olaparib, which showed statistical significance. Prima used niraparib, which showed statistical significance in BRCA mutant, non-BRCA HRD, and proficient also. And Paola is the trial where olaparib was added to bevacizumab, and this also showed benefit in both the BRCA mutant and the non-BRCA HRD positive. Velia was for velaparib, but it is not approved by FDA. And these are the other trials which Swapnil will explain. So determining the choice of maintenance therapy in resource limited context, HRD tests are expensive and hence reimbursement varies globally. So also if you add bevacizumab to PARP also it becomes very expensive and it causes significant financial burden. There is no strong cost effectiveness of HRD genomic testing in low resource settings. So key distinction is to make between HRD positive and negative because it determines whether maintenance you have to give PARP or bevacizumab or both. And platinum sensitivity can serve as a functional biomarker when HRD testing is not available. And it is because it is validated in platinum sensitive recurrent setting and reasonable to extrapolate these to frontline setting. So indicators of likely PARP benefit without doing a HRD test is that excellent response to neoadjuvant platinum chemotherapy suggests HRD positive phenotype and likely PARP benefit also. Indicators of likely bevacizumab benefit are usually poor neoadjuvant platinum response, upfront inoperable disease, stage 4 or icon 7 defined high risk patients like who underwent suboptimal bulking but they had residual disease on the scan. So these favor bevacizumab addition. So what should we do? Germline testing, somatic testing or both? So as per ESMO, so ideal approach is to offer both germline, somatic and HRD. But why both are important? Because a small proportion of germline BRCA mutated patients may have negative somatic BRCA. So that's why it's important to do both. But if only one test is possible to be done, then HRD testing is more practical on somatic tissue because it gives some detail about germline mutation based on the WAF scoring. Somatic mutations are found out and also genomic scores can be calculated based on that. So sequential testing strategy is the one which we follow in our hospital. We start with germline testing and if it is negative, we offer HRD testing to the patients. Also, if they're affordable, we can do germline testing in parallel or sequentially for the patients. So these are some of the FDA approvals for PARP inhibitors and some of them were withdrawn too. So olaparib you can see it is approved in first line maintenance with bevacizumab, first line maintenance in BRCA and recurrent maintenance in BRCA variant only. Whereas niraparib you can see it is first line maintenance in all, meaning that even in HRD proficient patients also it is approved. That's the only PARP inhibitor which is approved in HR proficient also, but there are some controversies regarding that. Also, niraparib is approved in recurrent maintenance, but only in germline BRCA variant patients. Rucaparib, there is only one indication which is given in recurrent maintenance in BRCA variant. So, how to add PARP inhibitors? So first, you have to take a. So first, the decision is made whether NACT has to be given or primary debulking surgery. And when that decision is being taken, it is best to do BRCA and HRD at that point of time because we can get many details through this. And if primary DKLB surgery is done, then adjuvant paclitaxel is given, and if NACT is opted, then paclitaxel carboplatin can be started, and decision has to be taken whether bevacizumab needs to be added or not. If bevacizumab is being added, then at the end of the treatment, we have to see HRD test. So if the HRD test is positive, then the Paola protocol can be followed, which is olaparib with bevacizumab can be continued as maintenance. If HRD test is negative and bevacizumab was given in the NACT or the adjuvant phase, then based on the GOG 218, GOG 262 or ICON 7, we can give bevacizumab maintenance only. If no bevacizumab was given in the NACT or adjuvant phase, then if the HRD is positive or BRCA is positive, then we can follow either the solo one, which is for olaparib, or prima one, which is for niraparib. If HRD test is negative, so usually we keep them on observation, but sometimes based on the prima trial FDA approval, we can also offer them niraparib. So maintenance PARP for patients with platinum sensitive relapse. So this is in second line. So there were three trials, study 19, solo 2 and NOVA. Study 19 and solo 2 was for olaparib, which shows statistical significance. Here you can see the PFS for solo 2 is 19.1 month compared to 5.5 placebo. And for niraparib, it was 21 versus 5 months in BRCA mutant patients and 9 versus 4 months in non-BRCA patients. So what are the future directions with HRD testing? So some tests fail to report results like HRD non-determinant despite the high cost and time critical nature. So conflicting results between Paola 1 and Prima trials in HRD negative and HRD non-determined groups. So we don't know exactly should we offer them or not. But some trials have shown that there are benefits with the HRD proficient. So should we consider them as proficient or not is the another question. HR function is dynamic, so it can change with treatment. So genomic scar assays which we do on My Choice and Foundation reflect historic HRD and they are not real time. So that is why the new concept of functional assays like RAD51 is upcoming. And there are various resistance mechanisms which are not captured by the HRD test for PARP inhibitors, like reverse mutations in BRCA1 and PALB2 which can restore the HRR competency, and other mechanisms like heat shock protein 90 stabilization, P glycoprotein efflux, replication fork protection, and parpylation restoration. Also, there is something called as tumor heterogeneity and sampling issues. So, spatial heterogeneity is something we should take into account, because when they, in some trials, when they took biopsies from two different sites of ovarian cancer patients, they found two different HRD scores, and one was proficient, one was deficient. So that's why in Athena trial, they are looking into something called liquid biopsies. Emerging combinations like PARP inhibitors with immune checkpoint inhibitors is also something which is looked into now. And so the future is that there are two more tests which are upcoming. One is called the mutation signature 3, which is basically whole exome sequencing and combined immunogenic score, that is My Choice test plus TMB, MSI, and other mutational burden. And this is known to outperform HRD assays which are present now, and maybe these are the future. So this is basically a resistance pattern for PARP inhibitors which I explained previously, like the glycoprotein P efflux and some other pathways which are not important. Thank you.
Very well presented. Even summarize from, it's been too much of data for you to share. Tell us the use of PARP inhibitors based on germline and HRD testing. I will clap and listen to you. Thing has to penetrate your mind. Correct, no? Hey, Mohan, you tell me you heard the presentation. No? What is the, how many cancers, what is the percentage of cancers which might be hereditary in origin? What is the percentage of hereditary origin? How many ovarian cancers, breast and ovarian cancers do you think will have a hereditary origin? What is the percentage? Vallish, you tell, go back. Go to the first slide.
It's for BRCA1.
Yeah. 15 to, you told the percentage, no?
BRCA1 mutations have 39 to 44% risk of ovarian cancer.
Hereditary, what? How many of them will have family history, and how many will harbor BRCA mutations? So Deep Sir's paper is also tells about 21%. 15 to 20% of ovarian cancers will have BRCA. You go back to the first slide, because they'll just listen and finish it up. And how many of the cancers present to your OPD high-grade serous in advanced stage, stage 3C and stage 4, out of 100, how much, what is the percentage of presentation in stage 3C and 4? How many stage 1 and 2 you've seen till now? In your 1 month of posting, you have not seen, no? Yes, 1 to 2 is less. How many of them present in advanced stage? At least a 75% of them. That is why we are discussing, we discussed NACT, we discussed adjuvant, and then we will discuss, I think, PARP inhibitors, no, we will just take with Jayabadam next time. I just want to know the basics. Now, Dylan, you tell us benefit of PARP. Have you read the TMH IPD meta-analysis by Dr. Seema? Please read that paper, no? All three of us are there. You must know the quantum of benefit from PARP inhibitors if germline BRCA is positive, if HRD is positive. What is the quantum of benefit? The quantum of benefit differs. What is the best benefit seen in which setting? हो गया तुम्हारा gynec posting is you are ready for the exam. Best benefit if germline BRCA positive. You should know the PFS in all settings from 42 months to 28 months. But if it is HRD negative, then you already told that niraparib is there based on PARP.
Yes.
But then we can give rucaparib, but the benefit is only 3 months. HRD negative, it is best to observe. However, if you have given bevacizumab in high risk settings, you can continue to give the maintenance bevacizumab.
Yes.
However, HRD positive, what is the benefit? I at least want you to know the PFS you told, na? Based on germline, HRD and HRD, that slide. And Vallish just tell once again the benefit. No?
So in frontline setting,
First you tell solo one time.
so solo one olaparib was
56
used,
months.
yeah,
I would like to
56
go
months,
ahead.
and Prima in BRCA mutant it was 22 versus 10 months, and in HRD positive non-BRCA it was 19 versus 8 months, and in proficient it was 8 versus 5 months.
Correct. So highest benefit is for germline BRCA.
Germline BRCA.
Then go down rucaparib trial here.
So rucaparib Ariel 2, where in platinum sensitive relapse it was the inclusion criteria. In BRCA mutant it was 12 months, whereas in LOH high, because foundation one was used for rucaparib trials, and the PFS in LOH high was 6 months and LOH low was around 5 months.
And if HRD negative, it is almost minimal benefit.
Yes, minimal benefit.
So maybe PARP inhibitors in recurrent setting, that we can do, madam, and then finish off. This much is enough. Good presentation. Thank you.